Dr. Suleiman, I think we are good to start. It's 9:05. Okay. Unmute yourself. You are muted. Unmute. Yeah.
Good evening, everyone.
Good evening.
Hello.
Good evening.
Good evening. Good evening, sir.
Yeah. We are all welcome to our weekly academic tonic. The presentation will be starting immediately. But before I call on the speaker, today we are honored to have two giants that shall be talking on oncology. Before I move on, let me also introduce myself. My name is Dr. Suleiman Ademola. I am a Nigerian and I'm a pharmacist. However, I am seated in Uganda. So before we call on the presenter, the first presenter, I want to recognize the presence of our fellows from the fellows of the Pharmaceutical Society of Nigeria. You are highly recognized and welcome. I also want to recognize the fellows of West African Postgraduate College of Pharmacists. You are welcome. I also want to welcome all clinical pharmacists and our guests and ladies and gentlemen. Like I said earlier, we are opportune to have two giants that shall be looking into oncology. The two giant presenters, they are specialists in their way in the area in which they are practicing. The topic for today is basically on oncology, and one of the presenter will be talking about how to set up an oncology in the pharmacy department, while the second presenter will talk about the role of the pharmacist in oncology. So the first person that shall be coming in is no other person than our able Assistant Director of Pharmaceutical Service and the head of Oncology Pharmacy Unit in Jos University Teaching Hospital. Pharmacist Emiya Adamu is a fellow of West African Postgraduate College of Pharmacists. He's also a member of the Judith Oncology Committee. He is a member of the Judith Albino Cancer Prevention and Treatment Committee. He is currently the chairman of Association of Pharmacy and Administrative Pharmacists of Nigeria. He is also a national interim secretary of Oncology Pharmacy Practitioner Association of Nigeria. He is a preceptor for students in the Department of Clinical Pharmacy and Pharmacy Practice, University of Jos. Before I call on him to come on stage, I want to call on volunteer to please give us an opening prayer. Should I call on someone to?
I'll pray. This Professor C. Osifo.
My spirit.
Father, we ask for your grace to listen attentively, and we ask that Lord will hear to help us build ourselves. And may you be with us throughout our discussions and our lecture. For in Jesus' name we pray. Amen.
Amen. Thank you so much, sir, Professor Siri. I pray that the knowledge we are going to derive from these two giant presenters will not only be contribution to the bundle of knowledge, but it will be beneficial to us as pharmacists. It will also be beneficial to our profession, to our dear country, Nigeria, and to the humanity at large. I want to remind us of our grand rules that while the lecture is ongoing, if you have any question, please put it on chat, or you wait till the end of the lectures and raise your hand. We also want to remind each and every one of us to please mute and put off your video so that it will not be interfering while the lecture is going on. We pray that God will guide us through as we are starting the presentation. Let me welcome pharmacist Emiya Adamu on stage to make his presentation. Thank you, sir.
Thank you, sir. Thank you very much, sir. Before I go on, I would like to say that I am not the national chairman of AHAB. I am the chairman of AHAB Jude chapter. I would like to greet all the fellows of the Pharmaceutical Society of Nigeria that are participating, the fellows of the West African Postgraduate College of Pharmacists, the host, Dr. Bello, the co-host, Dr. Suleiman, my friend, Pharmacist Sambe, and my co-presenter, Pharmacist Famakinde, and all other colleagues that are participating. Good evening to you all. I'm happy to be given the opportunity to present today. Before I go on, I would like to say that my presentation is, as the moderator said, is on the guide to setting up an oncology pharmacy and all the things that are required to be done after the oncology pharmacy is set up. Please, next slide. Next slide, please. Next slide. Next slide, please.
Okay, I'll come in. Hold on.
Okay. Yeah.
Okay. Let me see.
So before setting up an oncology pharmacy, before this slide comes up, before setting up an oncology pharmacy, the pharmacy department or the management of the hospital should be able to know the safe handling of this cytotoxic before before going into setting up the oncology pharmacy. The slide is not okay.
Okay, I'm coming. I don't know as well.
Oh.
Yes, hold on. I want to correct something.
Okay. So can I go on before?
Please go on. Go on.
I think you can continue while we are waiting for him.
Okay.
Okay, before setting up the oncology pharmacy, the pharmacy department or the management of the hospital should know the safe handling of this cytotoxic. The cytotoxic drugs are toxic, so they should know handle how whoever is going to handle the cytotoxic drug should be should be aware of the potential danger of these cytotoxic drugs. And that is why, you know, some professional bodies and associations, you know, came up with so many ways of handling these cytotoxic drugs. Like the American Society of Health System Pharmacists, came up with issued the revised, you know, technical assistant bulletin on handling cytotoxic and hazardous drugs. Then 2014, the NIOSH, which is the National Institute for Occupational Safety and Health, which was founded in 1970 in US, Washington, DC. They also came up with the NIOSH alert, which is on the prevention of occupational exposure to anti-neoplastic and other hazardous drugs in healthcare settings. Please, next slide. 2005, the Oncology Nursing Society also issued a safe handling of hazardous drugs. The pharmacy should take the lead in developing policies and practice for the safe handling of hazardous drugs. Next slide. Next slide. Next slide. What is happening internationally with Oncology Pharmacy? April 2013, the British Oncology Pharmacy Association also came up with this, that the Department of Health requires that all chemotherapy prescriptions should be checked and authorized by a pharmacist. Then the ISOP, which is the International Society of Oncology Pharmacy Practitioners. Some of our members in OPAN are also members of this International Society for Oncology Pharmacists. They also advocate that all oncology practitioners all over the world, that they should have a standard practice, international practice. Some are in full compliance, and some are trying to meet up with the standard practice, international standard practice. Next slide. Then next slide, please. So the design of the Oncology Pharmacy. The Oncology Pharmacy, you know, ideally, the Oncology Pharmacy should be divided into 3 areas: the dispensing and storage area, the Ante Room, and the mixing area that house the Biosafety Cabinet. The dispensing area, the dispensing area, a safe and secure area must be provided for the storage of drugs in accordance to the manufacturer's instructions or other legal requirements. Where applicable, pharmaceutical products must be stored in accordance with the Pharmacy Act. This has nothing to do with us. I do not know if we have the act here in Nigeria. Storage should be away from direct sunlight. Room temperature should be monitored and recorded, and air conditioner should be available. On-site refrigerator is required to maintain cold chain. Thermometers are also required with alarm for electricity failure. And also hand wash basin should be provided with drying facilities adjacent to it. The wall behind the wash hand basin must be okay. So sorry, can you go back? Because I've not been seeing the slide, so I've been okay. Okay, next slide, please. Okay. Healthcare workers may be exposed to hazardous drugs through these ways, but for the manufacturing and distribution, that the exposure is in the industry. The exposure starts from the receipt of the drugs in the hospital, from the receipt of supplies of the drugs, the storage, the transportation. Next slide, please. Compounding, administration, and waste handling. Next slide. Okay, absorption one can get in contact with the cytotoxic drugs through inhalation, maybe during preparation of the cytotoxic drugs, or during waste handling. One can come in, can come in contact with these cytotoxic drugs that are dispersed, through the droplets or the dust that is being dispersed into the air, and also through intact skin. One can get absorption through intact skin when the pharmacist or whoever is constituting the drug comes in direct contact with the drug or the contaminated surface, work surface. And also injection. One can come in contact through these cytotoxic drugs through contaminated food that are kept in the refrigerator that cytotoxic drugs are also kept, or food that are kept within the area that these cytotoxic drugs are reconstituted. These are the effects of the cytotoxic drugs. Those who are involved in the mixing of the drugs, over time, they will start coming down with the side effects of these drugs, and eventually they can even come down with cancer. Next slide, please. There are things that are supposed to be considered before setting up this oncology pharmacy. One is space. There must be enough space for the dispensing area, for the clean room, which is the constitution room that this cytotoxic drug are reconstituted, and also there should be space for storage of these drugs, and also there must be space for waiting. And then equipment, there must be equipment available. Equipment like PPE, like thermometers, refrigerators, biosafety cabinets, disposal bins, and so many other things that are required in the oncology unit. And then there must be personnel, that the oncology pharmacists, the cleaners, the pharmacy technicians that are going to help they are going to support these pharmacies in the oncology pharmacy unit. And there should also be funds available, earmarked for purchase of drugs and other equipment that are needed in the oncology pharmacy, and also incentives for pharmacists who are working in the oncology pharmacy because of exposure. And then there should also be a committed oncologist. Then there should also be a committed and supportive head of department. Like in my hospital, my head of department was very supportive. He was instrumental to the setting up of the oncology pharmacy. Next slide, please. Then design of the oncology pharmacy. Ideally, the oncology pharmacy should be divided into 3 areas: the dispensing area and the dispensing and the storage area, the ante room, and the mixing area that house the biosafety cabinet. That is the clean room. It's also called the clean room. Next slide, please. Then the dispensing area, the dispensing and storage area. There must be a safe and secure area provided for the storage of these drugs in accordance to the manufacturer's instructions or other legal requirements. Then the storage of pharmaceutical products should be in accordance with the Pharmacy Act. This has nothing to do with us. Then the storage should be away from direct sunlight. Room temperature should be monitored and recorded, and air conditioner should be available. Next slide, please. An on-site refrigerator is also required to maintain the cold chain. Then the thermometers are also required. The thermometers are required in the dispensing area and also in the refrigerator to maintain the room temperature. And because of this thing, because of the heat generated in the clean room as a result of the PPE that whoever is reconstituting the drug wears. That is why the thermometer has to be there to maintain the room temperature in the range of 18 to 22 degrees centigrade. Then hand wash basins should be provided with dry facilities adjacent to it. Wall behind the wash hand basin should be impervious, should not be impenetrable to liquids. And then one should make sure that no coffee cups are kept in the area. An adequately large work surface for collection and dispensing of prescription must be provided. Hazardous drugs should be stored separately from other stock to prevent contamination. In Jos University Teaching Hospital, we have 2 refrigerators, one for the cytotoxic drugs and the other for other drugs that are not cytotoxic. Next slide, please. Then the Ante Room. The Ante Room is close to the clean room, which is the reconstitution room where the drugs are mixed. And like Zaria has Ante Room. That is where the pharmacists wear their PPE before they enter the clean room. And once somebody is in the clean room, the person doesn't go out until he's done with the reconstitution. The clean room has to be clean. It has to. There shouldn't be any contamination of the clean room. And it's a place where the technicians perform their support tasks, and also is the place where patients bring their drugs, and then they take the drug into the clean room for reconstitution. And it's usually equipped with sink, cabinets, and bench. Like the one that ABU Zaria has, it has cabinets where the PPEs are kept. Then the mixing area that house the Biosafety Cabinet. This is the clean room where the drugs are reconstituted. The construction material, right, all the surfaces, the construction materials that are used are in such a way that all the surfaces in the anti-neoplastic mixing and storage areas should be impervious. Walls should either have vinyl or enamel paint that can withstand repeated cleaning and disinfectant. Then the doors should have closures and elbow operating handles. The ceiling should be unitary constructed and light fitting. Next slide, please. The floor should not be fitted with a carpet, but constructed of a concrete base and finished with a smooth, impervious, washable surface so that they can be easily cleaned. Next slide, please. Then there should be space in the clean room so that there will be free movement. Then also the equipments that are installed, that are fixed, that cannot be moved, should be in such a way that will be installed that people can have free movement within the work area. Next slide, please. Then the Biosafety Cabinet. The Biosafety Cabinet is in the clean room. The Biosafety Cabinet has 3 protections. It protects the person who is reconstituting the drugs from being contaminated. It protects the environment from also being contaminated, and it also protects the product from being contaminated. Next slide, please. Next slide. The International Society of Oncology Pharmacy Practitioners recommend the Class 2 Type 2B Biosafety Cabinet for reconstituting drugs. The Class 2 Type 2 Biosafety Cabinet exhausts all the inflow and downflow of air to the atmosphere after filtration without recirculation inside the cabinet or return to the workroom. And that protects the product from even being contaminated. There is no recirculation of air within. Airflow is drawn around the operator into the front grill of the cabinet, which provide personal protection. Next slide, please. Then the Biosafety Cabinet has HEPA filters. That is high efficiency particulate air. The the laminar airflow reduces this turbulence in the work zone, minimizing the chance of cross-contamination along the workbench. Environment protection is achieved by HEPA-filtered exhaust air from the cabinet. The cabinet should be on casters so that it can be moved when validating the hood. The newer design cabinet do not have to be moved to remove the HEPA filter. The one Zaria has, it does not have to be moved. This is the old one. This one has extraction unit. If you can see, this tube, the tube above is projected above the building, 2 meters above the building. And this is the old model. The one that Zaria has is a 2018 model. It doesn't have this extraction unit. The tube that is projected above the building, 2 meters above the building. Next slide, please. This is the one that Zaria has. This one is fixed. This one has, you cannot move this one to remove the HEPA filters. This one, the HEPA filters can be removed while the biosafety cabinet is, in place. Next slide, please. This is how the biosafety cabinet works. The air that comes in from above, is filtered. The air around whoever is constituting the drugs is drawn inside the biosafety cabinet. Is also filtered, and then it's also filtered out. There are HEPA filters, that these airs are filtered out so that the environment will not be contaminated. Next slide, please. The extraction, the other one that the old model has the extraction system that, as I said earlier, the extraction system should be fitted with a carbon filter and a HEPA filter, and is projected above the building, 2 meters above the building, and is also fitted with an anti-blowback unit to prevent any outside air entering the extraction duct in the event of fan failure. The extraction system is monitored by pressure switches, which should set off an alarm in the event of low or unsafe extraction rate. The oncology pharmacy. There are things that the oncology pharmacy is supposed to have, like the temperature is supposed to be, the temperature of the oncology pharmacy unit is supposed to be considered because of the PPE that whoever is reconstituting the drug wears that generates heat. So the temperature will be within the range of 18 to 22 degrees centigrade. And also the size of the room is also put into consideration. There can be impairment of movement within the workbench. Next slide, please. There should be minimal requirement for room size. Extensive information on minimal separation is given in British. This one is the telephone or intercom system should also be in room, and this would help to prevent unnecessary entrance into the reconstitution room. Whoever is in the reconstitution room should be able to communicate easily with people outside the reconstitution room. To prevent people from coming in and out, contamination of the area. And then there should whoever is constituting should be comfortable at the biosafety cabinet. The chair that is used should be height and also should be made of material, washable material. Next slide. Then the ideal oncology pharmacy should also have the following: the pass-through hatches. These are small doors that one can easily pass with. Also, there should be air supply. There should be pressure differential. Should not be stuffy, and then there should be an air conditioner to keep the place cool. The handling of cytotoxic drugs. The handling of cytotoxic drugs should be done by a professional. Acceptance of the deliveries should be performed by a professional, a trained pharmacy technician, and the pharmacy technician must be in his PPE. And in accepting these drugs, the pharmacy, whoever is accepting the drugs, should open to ensure that there are no damages. In the event where there are damaged, vials, it should be recorded. It should be recorded and captured, and then the drugs should be transported, to where the drugs are going to be stored properly. Next slide. Next slide, please. The protective equipment. The personal the gloves, the gown, the gloves. The gown should be a long sleeve and should be at the neck, and also it should be a disposable one, and should not be used outside the working area. And then the gloves too, the one should be doubled. The gloves should be, the one that is required is the latest glove. That one offers a greater degree of protection than the gloves that are made from PVC, that is polyvinyl chloride. Then the gloves reconstruction. Whenever after 30, the outer glove should be changed, and where there is damage, the glove should be changed immediately. And when there is stain, the drug should also be changed immediately. Then there should be, the pharmacy should also have covers, shoe covers and masks. The mask that is this N95, the one that has respirator, but does not have, but still it protects. It protects. Next slide, please. This is how the oncology pharmacy is supposed to look. This is how the oncology look. When I went to visit Zaria, this is when I went to visit Zaria. Next slide, please. This is the reconstruction room in Jos University Teaching Hospital. And this is how we appear, and sometimes we wear the complete overall. This, then personal hygiene or smoking or should be prohibited in all areas. Use regularly and correctly. Next slide, please. Yeah. Handling of the slide. Next slide, please. The cytotoxic drugs are in calculation. Cytotoxic calculated based on the calculation. They don't seem like other drugs. The dose based on the person's body surface area, except for carboplatin. The dose is a function of the patient. The formula for calculating carboplatin.
Hello, the speaker. We can't hear you anymore.
Hello.
Can you take over? I think he has a network issue. Dr. Ademola. The moderator, can you unmute yourself and address the decision? Okay, thank you.
Hello.
Yeah, we can hear you. Yeah.
Yes, I think we are having issue with the presenter. So we continue while we await him. And just like you have seen, he's talking about the calculation in relation to the weight and the height of the patient. And he has given an example of a particular drug, carboplatin dose, and that is the area in which we have stopped. And he made mention that we take into account the height, the age, the weight, and the gender, and the creatinine clearance of the patient before we do the proper calculation. And he gave an example of the carboplatin in which the area under the curve with the creatinine clearance plus 25 milligram will be used. Usually, they use area under the curve is between 5 and 7, and then the formula for to know the creatinine clearance is also shown, and the scale is actually constant. But when it comes to the female, 0.85 is usually used, while in the male counterpart, it is the constant K that is provided that is usually used. So next slide.
Okay. Coming. Let me check again.
So I think is actually on the last slide while he had that issue.
Okay.
So we are going to wait for him to do his closing remark. But while we are waiting for him, we are going to introduce the next speaker. But before I introduce the next speaker, I also want to say that he has given us a lecture that is highly important and germane. I remember while I was still in university in the early 90s, when we got to oncology, I thank God I have looked through, my lecturer is not here now. So they actually told us that the oncology is, the cancer diseases is the diseases of the white. So they are actually teaching us now for some of us that we want to go to the other side of the world, for us at least to know that there are diseases they call cancer diseases. So in those days, we were just being given. But today, we all know that this has come to live with us, even in Africa. So, and for people like him that have gone into that specialization, I think we thank him so much for the knowledge. While we are waiting to come and give us the summary, I also want to say that whatever question you have for Pharmacist Adamu, please hold on to it. At the end of the second lecture, we shall entertain the lecture. We shall entertain the question. I am going to introduce the second speaker, a man of many parts. He is no other person than the pharmacist, Dr. Famakinde Akintoye Ayokomi. He is a Deputy Director of Pharmaceutical Services and Head of Clinical Pharmacy Division in Oncology and Hematology Pharmacies of Federal Medical Center, Owo, Ondo State. He is a pharmacist, like I said, and he is a man of many parts. He has a certificate in French and German languages. He also has a postgraduate diploma in computer science. He has 5 masters. I said he has 5 masters. He has a master in clinical pharmacy. He has a master's in public health, another one in bioethics, information technology, another one. He has a master in business administration, and he is currently doing his PhD in clinical pharmacy. Pharmacist Dr. Famakinde Akintoye Ayokomi is a fellow of Pharmaceutical Society of Nigeria. He is a fellow of West African Postgraduate College of Pharmacists. He is also a fellow of Healthcare Informatics Society of Nigeria. He's a fellow of Institute of Information Management Africa. He's a fellow of Institute of Professional Managers and Administrators of Nigeria. He's a distinguished winner, service winner of Association of Hospital and Administrative Pharmacists of Nigeria. He's also a winner of a National Honor Award of Federal Republic of Nigeria and Oyo State Honor Award winner. He is a member of Planning Committee, International Cancer Week and Scientific Conference organized by Federal Ministry of Health and other cancer stakeholders at Abuja in 2009, 2010, and 2011. He is a member of the panel of judges of the poster presentation of biomedical research during the Commonwealth Pharmacists Association Conference at Accra, Ghana in 2009. He is also a member of the International Organization of Research and Training in Cancer. He's also a member of African Organization for Research and Training in Cancer. He's a member of the Cancer Society of Nigeria. He's a member of International Organization for Hospice and Palliative Care. He's a member of Palliative Care Society of Nigeria. He's a member of the National Medical Informatics Association. He's a member of the National Bioethics Association. He is also a member of Bioethics Society of Nigeria. He's a member of Association of Good Clinical Practice of Nigeria, and is a member of Society for Public Health Professionals of Nigeria. Pharmacist Dr. Famakinde Akintoye Ayokomi is a specialist in oncology, hematology in Federal Medical Center, Owo, Ondo State. He is going to be talking to us about the roles of pharmacists in oncology. I hereby give the floor for pharmacist Dr. Famakinde Akintoye Ayokomi. You are welcome, sir.
Thank you very much, the moderator. I'm highly humbled by the introduction. We thank God for the grace, and here we are today for this presentation. My own aspect of the presentation is role of an oncology pharmacist. I want to identify with the existing protocol. These are my introduction, the outline. These are my outline, introduction, cancer prevention, policy, building, administrative, training, cancer care, palliative care, pharmacovigilance, research and clinical trials, consultancy services, and conclusion. Before I go into the lecture proper, let me say a word on oncology pharmacy, which is a focused pharmacy practice, which involves provision of direct patients care, that is the cancer patients, and it goes on right from the prevention, from the populace to the cancer patients, and also to the dying patients and their relations. So as the lecture progresses, all that I've said concerning oncology pharmacy will be clear to us all. Let me start by this summary of the lecture. The role of oncology pharmacists involves the development and maintenance of clinical practice with patient care service, collaborating with medical and nursing personnel to optimize the pharmacotherapeutic aspect of patient care. And it also provides optimal selection of pharmacologic agents and design a regimen to maximize therapeutic benefits and minimize toxicity. It also involves the provision of daily follow-up on the clinical effects of the regimen with adjustments as necessary to achieve desired outcome, as well as attending rounds in inpatients or in the clinic areas. We direct patients' care and have contact with them for physical assessments and psychological signs of drug-related effects. Now, there are certain aspects of the oncology practice which many of us pharmacists do overlook. And by extension, most healthcare practitioners are trained in curative medicine, and pharmacists inclusive, and that is why we are not taking so much effort in practicing in this area, and that is the cancer prevention. Many preventive measures are not reported as healthcare activities, and they are seen as unimportant. And I want to begin from there. If we're able to tackle the cancer from this level, it will relieve us of so many burdens: economic burden, infrastructural burden, and so on and so forth. And we have 3 levels of prevention. The first one is primary prevention. These involve activities that are carried out to keep people healthy and prevent them from having diseases, in this wise, cancer. And those activities involves, examples are immunization, cancer awareness program, and so on and so forth. Also, improvement in the status of women, improvement in socioeconomic status and educational attainment of women to early age marriage, vaginal hygienic practices, no tobacco smoking, no prostitution, public health education, and use of HPV vaccine. While the secondary prevention involves preventive measures that lead to early detection or diagnosis and prompt treatment before it becomes serious. And this goes with this saying, early detection saves life. People can recognize early signs of disease and go for treatment before it becomes serious. And that's the second level of prevention. Also, for this second level, the objective is to detect early the pre-invasive and invasive stages and provide appropriate treatment. Pharmacists, oncology pharmacists can conduct pap smear in which it is used to detect cervical cancer. We can equally do visual inspection in collaboration with the pathologist. If we have a cancer registry there, there's nothing preventing oncology pharmacists to go in and look at the specimens Also, the colposcopy, which is best in combination with cytology, and also cervicography, a specially designed camera with a ring flash to take a photographic transparent of cervix after application of acetic acid. And the photographic slide is projected on a screen. And the tertiary prevention seeks to limit disability or complications arising from irreversible conditions. Interventions that help people from further deterioration or loss of function. You will all agree with me that most of the cancers that people have are occupationally originated, like lung cancer from asbestos, arsenic acid, radium, and in uranium mining, nickel and chromium. Nose cancer from leather dust, from people that are using leather, wood dust. Skin cancer also from coal, soot, diesel exhaust, ionizing radiation. Leukemia from benzene, ionizing radiation. And liver cancer from vinyl chloride monomers, refrigerants used in plastic industries. And also small and large intestine cancers from asbestos. All these are occupationally based. We equally have asbestos can lead to cancer of the larynx, esophagus, pancreas, kidney, colon. Minors have a lung cancer from radium gas, vinyl chloride, nickel, chromates, co-products, and so on and so forth. Even diesel from railroad crews, truck drivers, they have lung cancer. Painters, chemists, risk of lung cancer, bladder cancer from radiation, and so on and so forth. We have parabens from most creams, deodorants, antiperspirants, body sprays, which can cause skin cancer, breast cancer, and so on and so forth. So, oncology programs. Oncology pharmacists can embark on these programs, advocacy to policymakers, government, civil society organizations, organized private sector, international development partners. Oncology pharmacists can also embark on social and community mobilization, school health education, radio and television programs, publication, brochures, workshops, symposiums, seminars, conferences, newsletters, and news release, role play, in order to pass out information and create awareness to people in order to prevent the occurrence of cancer. So you will agree with me that all these roles, oncology pharmacists must embark on them and in partner with other healthcare providers. Let me share this with us. Like it has been rightly read in the citation. If you go to this place, you will see my name there. I was involved in the Federal Ministry of Health and other cancer stakeholders, which is also to create awareness on cancer. This is the work. This is when the wife of late Yaradua, our president, was leading us here. And you can see me at the back there, though some people covered me. this shows that oncology pharmacists must involve in all these activities, not only the hospital-based activities that pharmacists should embark upon. And even this one is more important because it covers a wide range of people, and also to prevent the occurrence of cancer. People say prevention is better than cure. We see opinion leaders who are invited. These are the crew of people that planned the cancer. All other people here, most of them are doctors. This is a former director of hospital services. This the breast awareness, the pink prof from University of Nigeria Teaching Hospital in Nsukka. That's Professor Okoye. We have press men here. This is the president of World Medical Association who came to join us in this campaign against cancer. And this also we translated into our local area. This is at Federal Medical Center Owo. You see the people, cross-section of people that were there. See the cross-section, cross-section, cross-section. You agree with me that after the lecture, these people will not go home the same again, and it will have a great impact in their life, because most of our lifestyle and occupations predisposes us to cancer, and they will carry the message to their communities. These are the cancer team, cancer committee members. Yes, another area where oncology pharmacists can play a very great role is health policy building. Policy is a purposeful planned attempt to establish principles and programs designed to address perceived problems. Public policies are carried out in the name of the people as a whole, and they affect the public interest. While health policy includes actions by public, private, and voluntary organizations that have an impact on health. How can oncology pharmacists be involved in this? He has to get acquainted with the steps in policy formulation. And this includes problem situation, agenda setting, policy formulation, policy adoption through legislation, and implementation, as well as evaluation. So in this case, these are examples of agenda setting. These were the agenda set during the International Cancer Week. We emphasize that health should be made a political one, and also that National Cancer Registry and replication of same at states and local governments should be established. Also, that federal government should designate more tertiary hospitals for cancer treatment. 3 tiers of government were joined to lend their support to cancer prevention and production of control, prevention, community advocates, and so on and so forth in all the 774 local governments. We have so many agenda that were brought up, and we divided ourselves into groups in order to analyze the problems and now formulate the policy for ratification by the whole body. And as an oncology pharmacist, though this is not part of our curriculum, I have to go to AF, Association for Reproductive and Family Health at Ibadan, to learn policy formulation. And people that are at Ibadan, they will know this is Professor Bamboye, and he taught me very well. And also, all oncology pharmacists should also learn how to formulate policies that borders on health, not only oncology, but specifically they can make impact in this area. And you will see a lot of examples of policies, National Cancer and Control Plan. You know that pharmacists should have made a tremendous impact in this area if we are involved. Also, the National Cervical Cancer Policy, the guidelines for management of pain, national policy for controlled medicines and its implementation strategies. Yes, some of our colleagues were involved. The chairman of Cont, that's Dr. Dan Oruwese, was involved in this. But more pharmacists, especially oncology pharmacists, should take the responsibility of formulating policies that borders on cancer care in Nigeria. Another role of oncology pharmacists is administrative role. Oncology pharmacists provide managerial responsibilities. You cannot just burst into hospital and start the activities of cancer like that. All this chemotherapy, radiotherapy, and so on and so forth, without first of all put some administrative structures in place. And these are the roles that pharmacists need to be well acquainted with and also do. So they provide managerial responsibilities for the operations of hematology oncology units, including process improvements, completing performance reviews for pharmacy staff in the unit, and also to maintain the oncology formulary. Oncology formulary is very, very important in hospital setting, and also in Nigeria as well. The one we have in Nigeria is an essential medicine list. The impact of oncology pharmacists is also required in formulating and compiling the essential medicine list. Under administrative is to design, support, and implement policies to provide effective and efficient use of resources for ensuring that budget quality and value targets are met in collaboration with the director of pharmacy. In this case, he has to do fund flow, the economic burden of cancer on the facilities and even on the patient, and marry them together to formulate a budget. And this is very, very important in hospital setting. Is to develop, review, assist, and maintain in collaboration with members of the department various protocols and regimens. Participates in committees, including not limited to pharmacy steering committee, chemotherapy or biotherapy subcommittee, pharmacy and therapeutics committee, executive council of hematology and oncology, as well as participating in the staff meetings. Another area which many of us are well acquainted with, we are familiar with this area, that is the pharmaceutical care of cancer patients. I don't need to be giving us the definitions of pharmaceutical care. Is there? Let me go straight to this area. Now, pharmaceutical care process. Here, we adopted the SOAP method in which when the patient first come to the hospital, either as a referrer or a new patient, there has to be clerk. In this case, we call it clerkship. We take the subjective findings, objective findings, and assessment. And we have all these acronyms that are put there. Assessment, we use CORE. We have to know the condition of the patients or the patient's need. Which kind of cancer, at what stage? Then the outcome decides for our intervention. Is it clinical, humanistic, economic? All of them has to be taken into consideration. Then the regimen that is to be used for the patient. Here, the PRIME acronym, pharmacy-based problems have to be assessed, risks to the patient, interactions, mismatch between medications and condition of patients or patient's needs, then the efficacy. All these are the work of oncology pharmacists, as well as evaluation. After this, then the plan has to be made. And with the acronym of PROSEC, we have to do pharmacoeconomic evaluation to see which options are best for the patient. Then recommendations to the prescribers or nurses. Then observing patients and reassessing. Safety, efficacy, and counseling. And the last and very important one is documentation. And with this, we have this form to take care of all that I've said. This is pharmaceutical care form. And all the parameters that I've mentioned are there to take the history of the patient. These are the forms. This is where you have your goal of treatment, the care plan, and monitor review. Then these additional notes. Yes. This also add the things that I've already mentioned: patient's assessment, prior counseling, patient's education and counseling, patient-specific pharmaceutical care plans, drug treatments, and so on and so forth. And my colleagues has already mentioned the areas of drug treatment, but I will get to that area very soon. And it's not very easy the way people treat other patients when it comes to that of cancer patients. Why? Because of psychosocial issues that surrounds it. And in this case, ethical issues in cancer patients' care is very, very important. So the oncology pharmacist must have knowledge of ethical issues in cancer patients' care. And these are to respect the patient's autonomy, informed consent, don't do anything without getting the consent of the patient, non-disclosure of the information, emergency care if needs be, futile interventions. You have to know. Don't just keep on doing whatever you want to do. If it's going to be futile, it's going to waste the patient's money, you don't need to go into that. Then acting in the best interest of the patient. Conflicts between beneficence and autonomy. In this case, there may be some patients that needs, maybe it's a Jehovah's Witness, he needs blood and so on and so forth, and he refuses taking blood. So you need to take into consideration the conflict between the benefits that the patient will derive from the blood and the autonomy. Assessing capacity to make decisions. Some of them may not be able to take any decision. Then when it comes to the use of surrogates, then the standard of surrogates that we take that decision, as oncology pharmacists, you have to be well acquainted with this so that you don't just run foul of ethics. Then decision about life-sustaining interventions, misleading decisions, extraordinary or ordinary care. You have to be aware of this, the difference, withdrawing or withholding interventions. Do not resuscitate, assisted suicide, care of dying patients, conflict of interest, maintaining confidentiality, allocating resources justly. You may have so many patients, cancer patients, and the resources may be little. So no preferential treatment. Don't just say this is a big man, a chief, or a politician that comes from this. Then you have to favor one, and all those ones, you have to be fair and just. Then assistance with ethical issues, financial incentives. Some companies might bring in their products, no financial inducements, no denial of coverage. Gift from pharmaceutical companies should not be anything to you as oncology pharmacists, because all these are ethical considerations. Occupational risk, mistakes, no misleading information for other healthcare workers. If you do that, there are penalties for it. Then learning clinical skills. You have to continue to learn, to upgrade yourself, to be current with new trends. Then impaired clinicians, and also conflicts for trainees. You don't just use them anyhow to train students without getting their permission. All these ethical issues while taking care of cancer patients are very, very important. Then let me say this. I'm very glad that our moderator is a lawyer. And with this, let us, any oncology pharmacist must know that even a clinical pharmacist, be it community, be it hospital, when a patient comes to you, whether there's no written agreement, be sure that there has been a contractual obligation. There's a contractual obligation from you for opening your premises as community pharmacists. Maybe you're an oncology pharmacist, you are working outside. Once you open your pharmacy for people to come in, there's a contract between you and that patient. If it is hospital also, when the hospital is open, there's a contract between you and that patient. So the obligation is for you to perform efficiently and satisfactorily. And in law of torts, irrespective of whether or not a contract exists, they owe a duty of care to those who are to be affected by their services, who can therefore maintain an action against them in negligence for breach of that duty. So it is very, very important. We need to take this into consideration. Medical negligence. Negligence is ability. Inability is the inability of a person to foresee the probable consequence of his acts or omission. Why I'm saying this, there's no point rolling out the roles of oncology pharmacists without letting us know the risk that is attached. And that is why I'm talking about the contracts and medical negligence. So the tort of negligence is defined broadly as the breach of a legal duty to take care which results in damage undesired by the plaintiff. In this case, the cancer patient. And the tort has three elements. They are duty of care, breach of that duty, and damage to the person resulting from that breach. So, duty of care. The patient has the ultimate choice of whether to seek medical care from you or elsewhere, consciously or subconsciously. So in legal parlance, the test for the determination whether a pharmacist or the defendants or a patient, which is cancer patient, that is the plaintiff now, a duty of care is a foreseeable test. I will explain. The test was first formulated in the celebrated case of Donald and Stevenson by Lord Atkin. It is tagged the neighborhood principle. The test enjoins that a person must take a reasonable care to avoid acts or omission which can reasonably foresee will be likely to injure your neighbor. Our neighbors are persons who are so closely and directly affected by our practice that we ought to reasonably take contemplation has been so affected when we are directing our minds to that act or omission. Now, we know that drugs used in treating cancer, they are cytotoxic. And like Paracelsus says, even in ordinary medicine, the statement concerning drugs shows that a drug is likely to injure a patient, even not to talk of cytotoxic medicine. He said all substances are poisons, and there's none which is not a poison. So the right dose of a right drug to the right patient at the right time for a right condition differentiates the poison as a remedy. In this case, what I'm saying in essence is that we have to take precautions whenever we are attending to this set of patients, the cancer patients. Now, let me talk about the breach of the duty. Breach of duty has been considered to be omitting to do something which a reasonable man, guided upon those considerations, which ordinarily regulates the conduct of human affairs, will do, or do something which a prudent and a reasonable man will not do. You see, when you are treating a patient, people, even the people regarded you as a reasonable person. No reasonable person will be allowed to take care of anybody who is sick. So in this case, if you now breach your duty, if you are negligent in that duty, then you have breached it. And the third aspect of it is risk factor. In everything we do, even the safest of all undertakings, there is a risk. If the risk of injury or damage to others is very high, one would expect a reasonable or prudent man to have a rethink or to take more precaution. In this case, it substantiates that you should not do anything that will make your patient, cancer patients, to be at risk. And the likelihood of harm, the greater the likelihood that the defendant's conduct will cause harm, the greater the amount of caution that is required of us. When we know that this is a cytotoxic drugs, we need to take precautions, even in radiotherapy. In preparing handling the radioactive agents, we have to be more cautious. So that is what I'm saying in essence. Otherwise, we will be liable in the court of law. Then standard of care. As an oncology pharmacist, a specialist, a consultant, oncology pharmacist, that makes us to be far above other pharmacists. So the standard of care expected of an oncology pharmacist should be greater than that which a pharmacist should give. So in this case, we need to be up to date with current trends in managing cancer patients. Now, let me state this. I'm talking about the roles from pharmaceutical care up to this level. And you know that care of cancer patients is not by just one person. It's team-based. And it involves teamwork. Teamwork is the process of people actively working together to accomplish a common goal. An oncology pharmacist should be ready to work as a team with other healthcare professionals. And also we know that teamwork has its own problem and has its own gain. But in this wise, one needs to know how to integrate himself into this system in such a way that they work in the best interest of the cancer patients. And in the hospital, you have to be involved in the ward rounds. And the ward rounds are in 4 parts: patients care rounds, patients care meeting, and ward rounds, as well as therapeutic meetings. All this, we have to be versed in this. The patient's care round means that you have to, first of all, visit particularly a new patient in the ward within 24 hours of admission and before the general ward rounds or grand rounds. You review the patient's case notes and laboratory data. Then interview the each patient's progress since last visit. Then identify all drugs and monitoring drug use, and also to reassure the patient because they are psychologically troubled. So in this case, pharmacists should go there and have first-hand information concerning the patients. Then patient's care meeting. Patient's care meeting prepares pharmacists for adequate and effective participation in the ward round because you have first-hand information and you'll be able to flow very well during the ward round. And during the meeting, you will discuss the outcome of the rounds and make appropriate recommendations. Then, if there are new therapeutic plans, you outline it for implementation. And also new therapeutic plans and suggestions are then documented appropriately. And those are the spaces in the forms that I initially showed to us. Yes, in these forms. This is the area where you need to document all those findings and the plan. Yes.
Sir, you have 3 more minutes, sir.
Oh, 3 more minutes. Okay, no problem. Yes, chemotherapy. Chemotherapy preparation is also part of the roles of pharmacists. We have oncology pharmacy best practices concerning this, and my colleagues have already mentioned such. These are forms, other forms, and the chemotherapy other forms in which you can get, the other will come from the oncology doctor. Let me quickly talk about palliative care, which is also part of pharmacist roles. Those are palliative care. We are not ourselves when nature being oppressed us. This is William Shakespeare. The essence of this is that cancer patients, they have a lot of psychological issues, and also some are having pains. So the pains are not something that one can think about. And in this case, pain assessment is also part of the roles of oncology pharmacists. And those are forms for initial pain assessment, and these are for other pain assessment during the course of treatment. Yes, if you have any other issues to discuss with the information for doctors, these are the notes. For nurses, these are the notes. Yes, another role is pharmacovigilance. Pharmacovigilance pharmacists need to be involved in this because a lot of issues can come up in the course of managing the cancer patients with drugs. So all these ones are roles of pharmacists. And another one is research and clinical trials. So pharmacists are involved in clinical trials and research, which has to contribute to knowledge and also for the care of the patients. Also, the issue of consultancy services is also part of the roles of the pharmacists. Pharmacy and Therapeutics Committee, drug formularies formulation, EDL inputs, and food composition and nutrition. We have local foods that are used, very important in prevention of cancer. All these ones are the roles of pharmacists. Conclusion, professional colleagues, please know that life does not end and should not end when cancer begins. Thank you very much.
Thank you very much, sir. We are very grateful. You will agree with me, colleagues, that the two presenters have actually done justice to the topic. It is not something that we can understand in a day because the two presentations are loaded with vital information. Before I go on, I want to give the first speaker, Pharmacist Adamu, to give a closing remark or a summation or conclusion on, because he went off unannounced and he is back. So let him unmute himself so that he can give a closing.
Okay, sorry, I wanted to come back, but I couldn't. I had to change to my phone. Well, there are so many things that I wanted saying, but just that I will not be able to say now because I do not have time. I wanted to talk about about extravasation and then the procedures in cleaning of the pharmacy, cleaning of the equipment, and also procedures for cleaning spills, large spills and small spills in the pharmacy, and also talked about documentation. For people that are going to be in the oncology unit, they have to have there has to be their baseline values from laboratory values taken, and after some time, maybe 6 months, the values are also the tests are also carried out to see whether there are problems with there are problems, and if there are problems, those problems are also documented, and the actions taken are also documented. There are so many things that are involved that I should have bring to our notice, but it's just that there is no time. So, but how I wish I will have time again to make another presentation on this. But I'm grateful for the opportunity given to me. And, my co-presenter has mentioned so many things that I should have even said, most especially with regards to the Constitution. The Constitution is a very important aspect of oncology pharmacists. There are so many things that are involved. The Constitution alone is a topic of its own. Because there are so many things that are involved as an oncology pharmacist in the Constitution. There are so many things that are involved, like the flu to use in the Constitution. The administration sequence. The labeling administration sequence. The doctors do not know that. Once they constitute 3 drugs, they just give anyone. But there is the one that will come first, the one that will come second, and then the one that will come third. That has to do with vesicle and cell cycle specific and cell cycle non-specific. So I'm really grateful for the opportunity given to me. I must say that my co-presenter presented very well. Thank you very much.
Thank you.
Thank you, Pharmacist Adamu. And we are also very grateful to Pharmacist Dr. Famakinde Akintoye Ayokomi. We are very grateful. I am sure that the people have listened, and there are questions that we probably going to bring out some things that you will have the opportunity of explaining further. We also know that the people are going to have access to the slide. So if any one of us has 1 or 2 things that we need clarification for, we're definitely going to get in touch with you privately. Okay. So we are very grateful for, and I also want to create knowledge of the people that it's because we have 2 giants that are presenting the paper today. That is why we spent beyond our normal time. So I am going to open the floor for those that want to ask questions, give vital information or observation. But before I open the floor, I also have 2 observations I want to give. When Dr. Famakinde made mention of issue of law of thought and equity. And I think it is very important for us, especially the clinical pharmacists, now that we are fighting for the establishment of PharmD in all school of pharmacists. I think we need to review our law of pharmacy that is being taught in school. The issue of law of thought and equity need to be. And then we are also fighting for appropriate compensation as clinical pharmacy practitioners. So one of the things that we can also hold on to is the risk factors, because when you look at the risk factor, it should determine your level of compensation, and then your standard of care to your patients is also being used as a measurement of what services you are giving and what compensation that you need to get as a practitioner. So for the people of the policymaker, you can get in touch with those people so that we can be assisted and be appropriately placed as a clinical pharmacist. Now I'm going to open the floor for people to ask questions. You can put it on the chat, or you can raise your hand. I have already seen pharmacist Peter. So, Dr. Peter, you are recognized.
Can we hear me?
Yes, I can hear you, sir. We can hear you.
Good evening, my esteemed moderator and all who are here tonight. Actually, I wanted to say two things, and you have actually said one. You know, in other words, looking for a legal framework to protect, you know, what we do in the hospital setting would help us. However, that is just a pinch of an ice in the ocean, so to speak. The most important thing is the competence and the confidence in which we do what we do. And I see oncology pharmacy as one niche or one area that should silence every other healthcare providers so that they don't argue with pharmacists. I don't know how those of you in that area see it though, but if you look at the intricacies involved, especially the sequence of administration, one of the presenters have said, a lot of physicians may not know all those things. And most of the nurses may just be doing what they are used to do or routine. And for the mere fact again, that even from exhaust fumes, from the environment, from grease and other areas, patients can actually get cancer. Yes. And for the fact that even the preventive part of cancer is becoming a global issue. Yes, and we all know that non-communicable diseases are becoming the order of the day. However, most of the time, I bet you hardly find pharmacists there. I'm sorry to say that. So I want to challenge our presenters tonight, the two of you. Yes. If at the end of the day you are not mentoring anybody, you haven't achieved anything. Whatever we have presented tonight and we have listened to, we just meant for the academics or for the records. If these presenters do not have one or two persons they have mentored, because it is only the pharmacists you are mentored that will go tomorrow and say, oh, this is what pharmacy profession is becoming. We need to grow a trend of pharmacy practice. Yes. And I bet you guys are one of the few that people can address as specialists, so to speak. I bet you once you tell somebody you are a consultant, even if you don't have a degree, you don't have anything, but you can manage cancer, the person is unlikely going to argue with you because people see cancer as a specialized area. So again, the institution where you work, since both of you work in the institution, most of the time we know it's well established in the institutions. Why don't you begin to look at ways where you can package your responsibilities and send adverts so that the universities, teaching hospitals will recruit pharmacists that you can train. We want to see where probably there's an advert in an editorial newspaper where they are saying they want to recruit pharmacists, cancer pharmacists. I've never seen that before. Every day I see the university or teaching hospital looking for 200 workers, 50 nurses, 30 physicians. You even see so many other healthcare workers that are not being as popular as pharmacists. I have never seen any advert done for oncology pharmacists before. Please let this presentation be a wake-up call to us, especially the presenters and those of us that are here tonight, so that we'll use it as a fulcrum or as a base to grow our profession. Our profession is in their need. Clinical pharmacy is too slow the way we are going in Nigeria. The only way to know that is to go to the hospital. You hardly see patient engagement. You hardly see patient engagement. From all we have talked about today, I see a lot of opportunity for patient engagement, 100%. Thank you.
Thank you.
Thank you, Pharmacist Peter. I can see Dr. Uchebo Obi. Can you please unmute yourself and make your comments or questions?
Yes, good evening, everybody. I just want to commend the two presenters this evening. But my question is on research. Do you... Hello, are you hearing me?
Yes, I'm hearing you.
Yes.
Okay, my question is on research.
Okay.
I don't know how far you have gone with research. Have you done any research on oncology? And if you have done so, what is there anything you have done on the effect of natural antioxidants in cancer therapy? What I mean by natural antioxidants, using natural things. I don't know, because I trend, that is what we're looking at now, is seeing how we can. In fact, let's just answer the question. Have you done anything on antioxidants in
No, I've not,
cancer patients?
But a friend of mine have done a lot. That's a Professor Atawadi from ABU.
Okay.
He did a lot on natural and even local fruits that contains antioxidants and so on and so forth. That, in fact, if you need papers on that, I can send to you.
Yeah, I wouldn't mind. But from the research he has done, is it positive? Is it something that is worth doing?
Yes.
Okay. And then what other aspects of research have you done on oncology apart from that?
Practice-based.
And do you do it yourselves, or the professors around you do it? Is there anyone that the pharmacy unit?
I did it myself, and someone in collaboration.
Okay, can you share with us, even just one?
Okay, the collaboration between the collaborative work of pharmacists on outcome of pharmaceutical care of cancer patients. So we did the management together, but with specific roles of pharmacists, like pre-counseling, before chemotherapy, then monitoring of patients, the impact of nutritional care, and so on and so forth. So, and there are good outcomes.
Good. And were they published?
The pharmacoeconomic analysis of the management.
Okay, that's good. Thank you so much. I hope they were published.
Not yet published. But very soon they'll be published. I've done up to about 27 studies. Thank you,
sir. Is there another person that want to make any presentation? I can see Dr. Rita saying that there should be seminars for on-site training of oncology pharmacists in collaboration with PSN, PCN, West African College of Postgraduate Pharmacists. It should go along. It will go a long way to help us develop skill, and I think that is the way to go. I also want to say that we also seems to have a lot of researches, but we are not actually translating it to the benefit of the people that that they're supposed to get the benefit from. I do not know why African is always afraid of going into the clinical trials and get to the third stage and they go out of it. So most of the time we have so many papers, but they are always on shelf. I have a question for pharmacists and them.
Sorry, as regards clinical trials, I'm aware of the ones that are being done at UCH through Professor Olokpade from University of Chicago. They did a lot of, clinical trials.
Okay, sir.
Yes.
Okay. Pharmacist Adam, while you are giving your lecture, you made mention that no coffee cups should be put in the dispensing and storage areas. I was wondering whether we can put another cup, but the one of no coffee. So why no coffee cups should be put in dispensing and storage area?
No, there are people that like taking coffee. I just mentioned that, but other cups are not supposed to be kept in the dispensing area. Anything that even from the pack of the drug, one can be exposed to the cytotoxic drugs. So it's not only coffee cups. And for research, she was talking about research. We in Jos University, we are gathering data. We are trying to do this thing to see the efficacy of the innovator products and then the generics. So patients who are on innovator products, we are keeping them, we are taking their own data, we are looking at the efficacy of the drugs, and then those who are on generics to compare the generic and the innovator product. That is what we're trying to do now. We're just gathering data concerning that. But for your listing, anything edible should not be kept, or cups or anything that you use to eat should not be kept within the dispensing area or the reconstitution area. Yes,
Thank you so
sir.
much. Yes, because I saw in another slide where you mentioned that no eating, but when specifically, I was wondering whether there is a pharmacological explanation to that. And
no,
thank you for the clarification. I don't know whether if there's any other question, concern, observation by anyone so that we can call it a day, or somebody is Dr. Rital is also asking that Pharmacist Adamu should elaborate more on the sequencing of reconstructed drugs.
Okay, the administration sequence.
Yes.
Okay, we have if you look at the cell cycle, we have drugs that attack the cell cycle at a particular point, either the S phase or the M phase. Or there are some that attack all the phases. So those that attack all the phases are called the cell cycle non-specific. And those that attack the cell cycle a specific point are called the cell cycle specific. So in the administration sequence, we look at the vesicant drugs, the one that can easily irritate the blood vessels. Vesicant drugs are the ones that are capable of causing inflammation, pain, inflammation, and blisters that can easily lead to necrosis. So those ones are given first. It can either be from the cell cycle specific or the cell cycle non-specific, but they are the ones that are given first when the blood vessels are intact. And then the one that comes second is a cell cycle specific. And then the one that comes third is the cell cycle non-specific. But sometimes it doesn't work that way, looking at the compatibility of this drug or drug interactions. So sometimes it doesn't follow. So we look at those ones that will not follow and then try to bring them out and then administer to the patient before the other one that cannot irritate the blood vessels. So these are some of the things that the physicians do not know. And when we started, the physicians were the one doing it, and then I continued asking them, and they could not give reasons. They give anyone that they like. It's just that there was no time. I would have even talked on extravasation. Extravasation, but in Jos University teaching also, since we started, we've not experienced extravasation. Extravasation is just the leakage of the drug into the tissues or infiltration of the drugs into the tissues that can easily cause necrosis. And then there are ways in managing them. We educate the nurses on how to manage those extravasation when it occurs. But in Jude, we've not experienced it. And then the extravasation is from the vesicant drugs. And then, sorry, can I explain more? The extravasation again, we train the nurses. There are some of the drugs that once the extravasation occurs, they will use hot compress, like the vical alkaloids that attack the M phase, like vinblastine, vincristine. So you use hot compress. Then there are some that you use cold compress. So we try to educate the nurses. And then there are drugs that are used for managing the extravasation. Thank you, sir.
Thank you so much.
Yeah.
From Dr. Bello.
Thank
Bello,
you,
please.
Dr. Ademola, for that good moderation. I want to commend the two speakers. I don't my cap for them, very detailed and scholarly presentation. But my question is for the pharmacist Adamu.
Yes, sir.
On the research you say is ongoing in Unijos, comparing patients on innovator drugs and generics.
Yes.
I want to ask whether you think the research is ethically okay when you place a patient on a medication that you are doubtful for the efficacy. Can you defend that ethically?
Okay.
Yeah.
You see, these patients, we try to maintain standard. We don't want to compromise when it comes to cancer treatment. So we don't want to compromise. We want every patient. We wish to have every patient on the innovator product. But some patients, are indigent patients. No matter how you try to tell them that they should go for the innovator product, they will tell you that they don't have money. And sometimes again, these patients will even not come back. When they see that the drugs are very expensive, they will not come back. They will be left at the mercy of at their own mercy. So that is why we those that insist to be on the generic, we try to, instead of not doing anything for them, so they place them on they place them on the generics. But there are some that can afford, and some NHIS patients that pay 10%. Most of them, because like for docetaxel, the difference between, we sell docetaxel 80 milligram 58,000, but the NHIS price is 55,000. So the difference is just 3,000. Those who are on NHIS can afford the innovator product. The innovator product is 58,000. Then the NHIS, the generic on NHIS is 55,000. So the difference is just 3,000. So the patients who are on NHIS can afford the innovator product. So we place them on the innovator product because the difference is just 3,000. So that is not that it's our wish to have some patients on the generics, but there is nothing we can do, sir. We don't compromise. Even if a patient brings two drugs, the same drugs, but the same drug from different company, we don't reconstitute. The drugs must be the same from the same company.
Yeah, thank you so much.
Yeah.
I don't think there is any other question or information. I can't see anybody's raising his or her hand now. Hello?
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 Good evening, everyone.
Good evening. Dr. Modupe.
Yes, thank you, Pharmacist Irinia Abi and Pharmacist Pharmacinde. Well done. I just want to add to what he said on drug, generic and branded.
Yes.
There are sometimes, as he has said, there are sometimes patients will come and in reality, they don't have money. So even when branded products are written, are prescribed for them, there are sometimes we have to sit them down and counsel them. Because some of them may look for money to buy the branded today, and they may not come back. So even there are sometimes you sit them down and ask them, can you afford this drug for so long, like 6 times, like even 3 times? And some of them will be, sincere with themselves and say, no, I cannot. So for patients like that, you call the prescriber, especially when they have indicated brand. You call the prescriber. This patient may not be able to continue or to go on the branded product like Tasotel or Elosatine. So the prescriber at times we agree, okay, let's go on generic. So it's not that they just place them on generic when they need branded, as he has said. So I want to appreciate every one of you for a job well done. from Idemia, from Jos, I believe.
Yes, ma'am.
Okay, well done.
You are a member of OPANT.
Yes, Pharmacist Olarewaju, UIT.
Yes, I'm the interim secretary.
Yes, I know.
Yes,
Well done.
thank you.
Thank you so much, madam. We
Yes,
appreciate
yes.
your contribution. Yeah, just like Dr. Famakinde has actually said, the way to go is to be involved in the policy making. If we have been a good advocate of health insurance, some of our issues will automatically be resolved. It is not an easy thing to dip your hand to the pocket and buy drugs of any type, not to talk of even a cancer drug that is relatively very expensive. I know what I am going to because I'm a teacher here, and I take my student for 2 weeks one round in a cancer institute, the pharmacy student, the medical and the nursing students. We know what we go through when you will see a patient today, the next time you go to see him is another set of drugs. And the reason is I can't afford this drug. Or at times you will stop for 2 weeks and the disease will relapse, and then you start passing yourself. And then even your own research will be jeopardized because now you are already monitoring the improvement. And now after 2 weeks relapse, you start all over again. So as pharmacists, I think it's our duty to be involved in the policy making so that we can push and push and push. So if there are no other comments, observation, I want to hand over to Dr. Bello Ibrahim.
I think we have Dr. Timmy, the chairman, CEPAN committee on call. Can she give the closing remark? Okay. Dr. Timmy, pray. Yeah. Yes, he's around. Yeah.
Good evening, everybody. Can you hear me?
Yes, we can.
Yes, we can.
Yes, good evening. I just want to thank these two wonderful presenters for this presentation this evening. We want to thank you so much. There are lots of questions. And for those of us who in our facilities, we even like to start. We would want to, there are so many things we would even want to know. Some of us who have already done the fellowship program, I don't think there's even, oncology there. And I'm just hoping, somebody even mentioned it, hoping that, West Africa, PCN, PSN, we look into it. This is a very interesting aspect. We are hoping that pharmacists who want to go into it should, our hope is that we don't know how we can, some people who we like to, how they can be trained. Somebody suggested, online training from time to time. We just hope, and then we know that with this, CPAN will look into it. Dr. Peter Afonsos, you are here. You are one of the, head of, CPAN trainee. We hope you include Oncology Pharmacy in your training in the CPAN pool of, experts. This is a very interesting aspect.
Dr. Timipre, Pharmacist Famika is even the one in charge of oncology for CPAN.
Yes.
That was why we brought him here. Yes, that was why we brought him here.
Thank you so much. Thank you so much. We are very happy, sir, to see you. Thank you. So now we are here. We are just,
the curriculum is ready. We are working on the manual.
It's all right, sir.
The curriculum is ready.
Okay, sir.
Oh wow. Yes. Wow, this is good news. Thank you so much. So we are.
It's just that I've not gotten the result, but they are working.
Yes, thank you.
Thank you. So we are hoping that the CPAN pool of experts, please do fast. Be fast about it, so that we know that there are so many young pharmacists coming up who will like to do that as part of their area of specialty. So I want to thank you so much for this wonderful presentation. Thank you, our wonderful moderator. You did so well. We really appreciate you too. Thank you so much.
Thank you.
So Yeah, so can
Thank
we just
you.
round up
Okay.
now? Please
Thank-
close in prayer. Father, we thank you for making it possible for us to come here tonight. Now we have learned a lot and now we want to go to bed. Father, please, we beg you to please protect us, guide us, be with us. We ask you for all these wonderful things that you have been doing for us. In Jesus' name we pray. Amen.
Amen. Amen.
Yeah,
Yeah,
thank you.
good night.
Good night.
Thank you.
Night,
Good night,
all.
sir.
Thank you very much. Thanks so
Yeah.
much.
Good night, Nigeria.
Good night.
Good
Thank you.
night,
Again.
Uganda. Good night, Uganda.
We are
Uganda,
on
good
total
night.
lockdown here.
Wow.
We're on 42 days.